Yeah.
Thanks for the opportunity, Dr. Rajesh, for the nice introduction. My topic is pterygium, how to manage. As we all know, pterygium is one of the common problems we see in our day-to-day practice and in our regular OPD. And many surgeons still consider the humble pterygium to be unworthy of their talent and skill. And this trivialization of pterygium surgery combined with the poor surgical technique are responsible for poor or variable surgical outcomes. As such, we do not have any set protocols or guidelines as to how to go about managing these different types of pterygium. A variety of procedures have been proposed, and the very fact of having so many surgeries says that we are far from knowing the ideal procedure. It's definitely a common problem because of the various surgical procedures. You can have various variable outcomes. As such, we don't have set protocols. When to operate pterygium? Surgery is recommended if the patient is symptomatic, if there is a progressive pterygium, if the pterygium disturbs vision because of the high astigmatism, if it is cosmetically unacceptable to the patient, so we should go ahead and knock it off. Or if there is a recurrence or a corneal recurrence, that is an indication for surgery. Just a case example, this particular patient has a grade 3 pterygium. If you see the topography, the patient has got almost 13.5 diopters of astigmatism. And after surgical excision of pterygium with a conjunctival autograft, this is exactly after 2 months of the surgery, the astigmatism is reduced to 2.5 diopters. I have a comparative analysis of this astigmatism. So this is the preoperative picture of the cornea, and this is the postoperative picture. And there is a 11.5 diopters of change in the astigmatism after the surgery. So there is a significant improvement in the astigmatism, and this definitely improves the visual acuity. This is an indication for pterygium surgery. What are the goals of pterygium surgery? The pterygium surgery should prevent a recurrence of pterygium, and procedure which is done should act like a limbal barrier so that there is no conjunctivalization of cornea, and it should have minimal or no complications, and it should be cosmetically acceptable to the patient as well as to the surgeon. So to achieve this goal, we should remove all the reactive fibrovascular tissue. We have to eradicate all mutant pterygium cells and restore the smooth surface, which is easy to re-epithelialize, and restoration of a normal limbal barrier. This will prevent further progression of pterygium. I think most of us are following this technique. This is a conjunctival autografting, a simple technique mainly for general ophthalmologists. I do it under infiltrative anesthesia, and this is almost grade 3, grade 4 pterygium. And ocular surface transplantation and its modifications have been tried with great success. This is a conjunctival autotransplantation. I take the graft from the superior bulbar conjunctiva. You just raise the conjunctiva by injecting lignocaine subconjunctivally so that you separate conjunctiva from the underlying retinans. As thin a graft as possible is separated, and because having tenons in the graft can cause a retraction of graft, and then excise the graft, place it on the Weir's scleral bed, and glue it or suture it. Alternatively, you can use even amniotic membrane as an alternative for conjunctival autograft, and this works well in primary pterygium. Both preserved amniotic membrane or even dried amniotic membrane can be used. So there was a study by Sheffer Zeng long back, almost 25 years old study, which compared conjunctival autografting with amniotic membrane transplantation for both primary and recurrent pterygium. And both the procedures are effective for primary pterygium. However, amniotic membrane transplantation alone is not effective for recurrent pterygium. We can go ahead and do a conjunctival autografting for recurrent pterygium also with good success. And we all know conjunctival autotransplantation is the gold standard in the management of primary pterygium. However, there are occasions when the superior bulbar conjunctiva is either not available or it's not sufficient. In such cases like conjunctival filtering bleb or a patient with glaucoma suspect or a patient having double head pterygium. Such cases, superior bulbar conjunctiva may not be sufficient to cover the base scleral defect. We can go ahead and do what is called conjunctival tissue grafting. So I've been doing it for quite some time now, and I just take a graft from the pterygium tissue itself. Even though it's a little difficult and tricky to take a graft from the pterygium, it's a little thicker as compared to the virgin conjunctiva, and it's a little brittle and tends to tear away, but it works well. You just remove all the fibrovascular adhesion, and then again you place it on the vascular bed, either suture it or glue it. And we published this procedure. I've done almost 90 cases of conjunctival tissue graft from the pterygium itself, and the results are fantastic. And in similar indications, I have even compared it with the inferior conjunctival autografting. Both the inferior conjunctival autografting as well as the conjunctival tissue grafting, it's comparable. This was again published recently in the last month issue of IGO. Coming to double head pterygium, we all know double head pterygium is a little tricky situation where we have to cover two bare areas. So various surgical procedures are available. Split conjunctival autografting, both horizontal and vertical split conjunctival autografting has been tried with great success. And just going to show a few of our technique. So this is a vertical, just an animation showing a vertical split conjunctival autograft. With limbal orientation, you're not able to cover the entire base scleral defect. So you have a base scleral defect here, and it's difficult to cover the entire base scleral defect if you're going to have a limbus to limbus orientation. And this base sclera is a potential stimulant for fibrovascular proliferation. Such cases, what we can do is slightly modify this technique. You just slide the graft down and place it on the base scleral bed. So without any limbal orientation. So this works very well. And this is just a video demonstration of the same procedure. I just split the conjunctiva vertically into two parts. And I have two defects. It's just without changing the orientation, I just place it on the base scleral bed. And this is the limbal end of the graft. So again, do it on the other side also. So that you are covering the entire base scleral defect without any base sclera being exposed. This works well, and this has been published way back in 2017. We published it in IGO, and recently in OGO, we published this vertically split unconventional way of doing this double head pterygium with a large number, more than 100 cases we have studied and published it in Oman Journal of Ophthalmology. And I have even compared vertically split conjunctival autografting with and without limbus to limbus orientation. Results are comparable, and it was published in December 2020 issue of IGO. And the results are comparable as far as recurrence rate was concerned and surgical complications are concerned. Horizontal split conjunctival autografting for double head pterygium can be tried. So you split the graft into two equal parts horizontally. And this is the upper part. You place it on the nasal or temporal defect, and the lower part, place it on the other side, and cover the entire defect. Again, it has been compared with the vertically split conjunctival autografting. The results are comparable. It was published in IJO by us. So recurrent pterygium, we all know recurrent pterygium is a different management problem, and experienced surgeon has to operate on this recurrent pterygium because can't afford to have a third recurrence or second recurrence after the first surgery. And so when do you call it as a recurrent pterygium? When there is a regrowth of fibrovascular pterygium-like tissue which crosses the limbus onto the cornea, or fibrovascular recurrence which is attaining the same degree of corneal involvement or corneal encroachment as the original lesion, or regrowth of the conjunctival tissue 1 millimeter onto the cornea or beyond. It's called recurrence of pterygium or recurrent pterygium. This is a typical corneal recurrence. This definitely needs surgery. However, this is a conjunctival recurrence. If you see here, this is a conjunctival recurrence, and this need not be treated. We can observe these patients. So what are the management options we have for recurrent pterygium management? We can use mitomycin C. We can go ahead with conjunctival autografting or conjunctival limbal autografting. We can go ahead with amniotic membrane transplantation or a combination of these. So mitomycin C 0.02 to 0.04% for 5 minutes, or there are different protocols which have been proposed by different surgeons. And this particular mitomycin C, it can be used intraoperatively or it can be used post-operatively. And 0.02 to 0.04% has been tried in many of the patients by many of the authors. And I don't use mitomycin C. This is very few cases only I have tried. And usually, if at all I use mitomycin C, I use it a Vexel sponge which is soaked in mitomycin C 0.02% is placed on the basicleral bed, and then I wash it thoroughly and place a conjunctival autograft on the base sclera. This gives double protection, and the results are good. And there has been a comparison. It's a nice study which compared 0.02% for 5 minutes with 0.04% for 5 minutes of mitomycin C. And as far as the recurrence rate was concerned, there is no difference. It is almost same. It's comparable. So we can go ahead, if at all we want to use mitomycin C, we can go ahead with the lower dosage, that is 0.02% for 3 to 5 minutes. And there was again one study which compared limbal conjunctival autotransplantation with mitomycin C. And as far as the recurrence rate was concerned, it is almost comparable. So we can, mitomycin C is as effective as limbal conjunctival autotransplantation for recurrent pterygium. Intraoperative versus postoperative mitomycin C. There are various studies which have compared the results of intraoperative usage with postoperative usage, and found there was no significant difference as far as the recurrence rate was concerned. So we can use it intraoperatively or postoperatively. However, one should be prepared to handle these dreaded complications. Per se, pterygium is not a blinding condition, but a complication like this, a scleral melt or a corneal melt like this, is a potentially blinding condition, and it's not acceptable for the management of pterygium. So I have stopped using this mitomycin C for the management of recurrent pterygium. My preferred technique is extended resection with the limbal conjunctival autografting. I do extensive resection. It's not a perfect technique. It's not as extensive as a perfect technique. So I do a extended resection. I go up to 0.5 to 1 millimeter beyond the conjunctival cut edge. And then I take a large graft with the inclusion of thin block of tissue from the limbus and place it on the base scleral bed. It's a large defect which is created and a large graft has been placed. The chances of recurrence with this technique is very less. The results are very good. And this is the treatment tree for different types of pterygium, single head, double head, and recurrent pterygium. So, what are the causes of recurrence after conjunctival autografting? Conjunctival autografting is a simple technique, but one should know the right way of doing conjunctival autografting. Insufficient graft size. If you see, there's a small graft here, and if the graft is small, you are creating a bare area here, and which can uh, be a potential cause for stimulation of this fibrovascular proliferation. And if you're taking a thick graft, this is thick graft, that is a conjunctival graft with the T nanos, it's not a, cosmetically, it is not acceptable to many of the patients. And graft retraction is another cause for recurrence. This is a small graft and it's a retracted graft. And graft inversion, if you place the graft upside down, if the epithelial side is down and stromal side is up, you end up having a necrosis of the graft. This rapid sloughing of the graft can induce a lot of inflammation in the surrounding area, and it can lead to conjunctivalization of the cornea, that is recurrence. And inadequate peripheral excision of the pterygium. If you see, there is a nice conjunctival graft here, but there is a small knuckle of tissue which is growing from below. So that means there has been inadequate excision that has happened during pterygium surgery. It's not been properly excised. So this is one of the cause for recurrence and persistent inflammation following pterygium surgery. This can happen in those patients who are working outdoors, who are exposed to sunlight and who are exposed to dusty environment constantly. After the surgery, if they are exposed to this kind of environment, because of the inflammation, there can be recurrence. So, what are the essential factors that can be considered to prevent or reduce the chances of recurrence? One is adequate removal of fibrovascular tissue and obtaining a large and generous graft. Obtaining a thin, tenance-free graft is another important point, and adequate stabilization of the graft. If you are using sutures, you anchor it at the limbal end so that there will not be any displacement of the graft. And if you are using autologous blood, wait for some time, and you can even patch the eye overnight so that graft stabilizes, and the next morning you can take off the patch. And proper orientation of the graft. If the graft is not oriented properly, if the epithelial side faces the sclera, then you end up losing that graft. So these are some of the essential factors that can be adopted, can be included in your pterygium surgery so that you can reduce chances of recurrence. So if you use a right surgical technique and a right method of graft fixation, you can end up having a good outcome in pterygium surgery. So finally, it is a surgeon's choice and expertise that should dictate the procedure of choice in these cases. Thank you very much.
Thank you, Shreesh. I think that was a very detailed and comprehensive presentation on management of pterygium, both primary and recurrent and double-headed pterygium. Now, there are a few questions which are there. I think, Raminder, you wanted to ask a question? Dr. Raminder?